Hello, my name is Ari Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to today's webinar, Resilience, Relationships, Readiness, and Recovery. Today's webinar is hosted by the Mid-Atlantic Telehealth Resource Center, and these sessions are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium located throughout the country, there are 12 regional telehealth resource centers and two national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. The consortium is collecting success stories from organizations, patients, and providers who have benefited from telehealth with support from a telehealth resource center. Share how your TRC helped make telehealth work for you for a chance to be featured along with your organization in our monthly consortium newsletter. And a few tips before we get started. Your audio has been muted for today's session. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using the chat to ask questions or make comments. Please also note that closed captioning is available and that is located at the bottom of your screen. Today's webinar is being recorded and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Kathy Wibberley, Director of the Mid-Atlantic Telehealth Resource Center.
Great. Thank you guys for joining us today. And I have some very esteemed colleagues who will be presenting this. They are all MATRC consultative service partners, and they have all had great experience working in rural areas where there has been any number of disasters and really real life opportunities to share stories. So we're going to just start with Steve North right now.
Hi, my name is Steve North. I'm a family physician and I practice in the mountains of Western North Carolina. The slide in front of you is the town I live in, Spruce Pine, North Carolina, on February 28th, 2024, when the flooding that hit after Hurricane Helene significantly impacted our town. Just the water levels came up from the river, and those are first floor awnings that you see on our main business street, often called Lower Street. And it disrupted lives and destroyed lots of homes, displaced patients of mine who now continue to live in campers, waiting for their homes to be rebuilt. And it was an unexpected, massive flooding event thought to be a 1,000-year flood. And I'm not going to dwell on the destruction and sort of allowing people to be voyeurs into the suffering of our community, but it definitely changed our community both for the positive and obviously for the negative for the rest of its existence. Next slide. So I kind of want to talk about over the next few minutes about how healthcare was affected and how telehealth did not solve all the problems in the world. So one of my roles is that I'm the medical director for the Healthy Schools school-based telehealth program. You may know my wife, Amanda North, who's the executive director of the Center for Rural Health Innovation. And we have been doing telehealth in rural schools this is our 15th year. And now we're in 10 predominantly rural counties in North Carolina, providing access at 130 schools to school-based telehealth. Helene challenged us, and there were so many barriers to the implementation of telehealth rapidly. Next slide. I'll let you read this so that I don't get choked up in Next slide. So these are the weather service rainfall totals, and our community is in the deep purple towards the north side of the region there. 24.12 is downtown Spruce Pine. And the water came quickly and it resolved somewhat more slowly. One of the major issues was that we had already had a week's worth of rain, and so the ground was saturated and nothing could be absorbed. And then all of the force of the water coming out of the hollers down little creeks, just blowing through homes, bridges, throughout our entire county. The federally qualified health center that I work for, we lost one of our practice buildings. It was damaged beyond repair by floodwaters, and we had just opened it to provide physical therapy services and behavioral health services. Next slide. So in Mitchell County, which is a rural county of about 15,000 people, we're located in between the Appalachian Trail on the north side and the Blue Ridge Parkway on the south side, halfway between Asheville and Boone. We lost all communication with the outside world. We were 4 days without electricity, cellular, landlines, or internet. That includes the transmitters for repeating radio signals from the State Patrol. And the first outside communication came when a hospital delivered a satellite phone, or I'm sorry, when Hospital Corporation of America, HCA, which owns our local hospital, brought a satellite phone in via helicopter on day 2. And this massive communication barrier was incredibly difficult to overcome. We had no outside road access to the county. The water treatment plant in Spruce Pine was destroyed and will take 2 to 3 years to rebuild. All of the Spruce Pine water intakes were blocked from the river, and therefore the town quickly went through its reservoir, required divers to go in and open those back up. And the only grocery store in the county was destroyed. And still 18 months later, no plans have been made to really reopen it. Next slide. This shows the extent of energy outages 10 days after the storm. And so Mitchell County is to the right of the 8, and you see the big red disaster rebuild zone, along with the complex repair zones there in Bakersville and Spruce Pine, where our patients are. But it was incredibly difficult to, yeah, it was incredibly difficult. I don't need to say anymore. Next slide. So at our house, and I live in town, it took 6 days for us to get a generator. We're fortunate to have natural gas at our house, so we could run it off natural gas. On day 11, we have 2 bars of cell phone reception. Prior to that, you had to travel to the edge of the county where the Blue Ridge Parkway is, and the mountain drops off about 1,000 feet to be able to pick up a faint signal and talk to friends and family. It was packed almost all the time as people walked up there to talk and let their families know they're okay. Electricity was restored 2 weeks later. On day 16, water was restored, but with significant restrictions, including a boil ban and a please don't flush anything down your sewer, because our sewer system is all backed up. On day 19, we got a Starlink from a church in Tennessee. And we also purchased a life straw cistern that would filter 5 gallons in 2 hours to share with our neighbors from our front porch. I think that it was a month later that our fiber internet was finally restored at home. It may have been longer. And it was 2 months before the boil advisory was lifted. And we continue to deal with intermittent power outages and water issues as secondary to the flooding. Next slide. So as I mentioned, my wife helps lead the Center for Rural Health Innovation. And we have 2 community access points in the northern end of Mitchell County, in addition to the schools. And CRHI was called on quickly to try and support healthcare in the community. The FQHC was offline for about 3 weeks because of no power, no water at any of the clinics. And so we thought telehealth may be a great solution here. Next slide. So the Healthy Schools program in Western North Carolina serves Madison, Yancey, Mitchell, Avery, Burke, and McDowell counties, all of which were dramatically affected by flooding and the aftermath of the hurricane. Next slide. School was out for a really long time. My son, was a junior in high school in Yancey County at the bottom, was out for 36 days due to damage to schools, damage to roads where kids could not get to school. And unlike during COVID, there was no internet at the home, so you couldn't just launch and do virtual days. But all the schools were also access points for our school nurses to present patients, and that was not available as a solution. Many of the schools were being used as relief centers and as support centers for the community. So either housing or places for people to drop off donations. Next slide. The Healthy Schools Network spans 10 counties, as I mentioned, and we are fortunate that several of our providers live and work outside of the area that was hit the hardest. So the blue stars are where our medical providers live. 3 live down in New Hanover County, which is Wilmington, and 1 lives in Cleveland County outside of the disaster area. The 2 yellow triangles are for local um, administrative staff who moved to other areas to help support the Healthy Schools Network. One went to live in Raleigh with her daughter, and the other went up to Johnson City, Tennessee, to live with a cousin because their homes were without water and power as well. But they quickly got the network up, and we were able to continue to see kids in Duplin, Pender, and Brunswick County, and we had medical providers available if we could make the connection to get patients scheduled. Next slide. We also have the Healthy Neighbors program. This is a really small map, but we have 2 access sites. If you go to the top of the slide, I'm not sure if I can use the pointer on this or not. It would help, but I'm not that good at Zoom. So at the top of the map, there's go up Highway 226. There's a little tiny crossroads called Beulah Dean, and we have a clinic there that's a community access point in um, an old school that's now a community center, where we staff it during the regular hours, 20 hours a week, with a former EMT, and they serve as a place for people to come and be seen. We see about 4 or 5 patients a week there, but it's a great community service. And then on the left or western edge, if you come down, there's another little crossroads called Tipton Hill on 197, and it was quite isolated. The typical road in, the bridges had been washed out, but um, we were able to get there with volunteer physicians, and but the internet was not there for us to connect, and we did not get Starlink there until after most of the roads were at least somewhat navigable. So difficulties in using telehealth equipment in these 2 sites, but we did use them for care. And one of the things that people talk about with telehealth in disasters is that it would be this amazing solution, but most of what we were seeing required care that could not be provided via telehealth. So wound care with someone who actually knew how to manage a wound, suturing, etc. Sprains and fractures, where really who's at that originating site is essential. And we had the volunteers to send to those sites, so didn't actually need to use telehealth often. Next slide, please. One of the things to be prepared for in a disaster is that you get donations. You get insane amounts of donations. So I don't know pounds, but I know that in the lower right-hand corner is the slides on the right are slides of pictures and boxes of donations. And we had two classrooms filled with donated medical supplies. Some things incredibly useful. We really appreciated all the insulin and the EpiPens because, well, the floods washed away all the nests for the hornets, but the hornets were still there and they were hungry and angry. And so people were getting stung all the time while going out to do recovery and rescue work. But we also got things like body bags, or not used, but expired suction equipment. So I think my public service announcement here is when there's a disaster and you want to donate because it feels good, please don't just go to your supply closet and empty out all the old stuff into a box and send it to those poor folks in Appalachia. Because A, we weren't managing people on vents. They could go to the hospital. But more importantly, it really slows down and gums up the system. One of the things that so this is at a decommissioned school in Spruce Pond, the major town. We did actually see one patient via telehealth who, although school being out and no real sense in, mid-October of when school in Mitchell County would come back, if you remember, they were out 30 days total. Um, we did do one sports physical via telehealth because the patient desperately needed to get their sports forms in so that they could run cross country or something. It was sort of humorous that that's what we did use telehealth for. Next slide. So the barriers that we ran into and places to begin planning for future state. Connectivity was a major issue, and that includes power. The devices. Well, we run a school-based program. And so when school nurses went home for what was thought to maybe be a long weekend with a little bit of flooding, they left their devices locked in the schools. Thank you for protecting the device. However, we now can't access it, and tracking people down without cell phones and routine communication is incredibly difficult. Communication is essential. How are you going to spread the word that you have a telehealth site or a clinical site? As we began setting up temporary clinics around the county, that was all word of mouth. Um, and then, minimal online communication as people brought Starlinks. Dr. Phil brought a helicopter filled with Starlinks and landed on the football field at the high school about 10 days after the hurricane. So that was beneficial to the community and a wonderful opportunity for him for a photo op. But you really need to think about who's at the other end. We were fortunate to have our nurse practitioners in the eastern part of North Carolina available. However, just because you have a telehealth unit available to see people, who are they going to connect to? And this isn't just about disasters, but in this setting, do you have a pre-existing relationship with an academic center, with bandwidth, with another nonprofit, so you can share the load of seeing these folks as they present? The other part is that we got a lot of volunteer physicians coming in. There's a challenge, and nurse practitioners and nurses, and some people claiming to be, and we're more just sort of disaster voyeurs trying to fake credentials and get in, but to provide care, which is really dangerous. But knowing that this load of volunteers comes, where do you maximize the utilization of your telehealth equipment for the greatest benefit? In the next county over, there's a field hospital that got set up at the volunteer fire station, and one of the nurses there, in conjunction with a physician who runs the palliative care program at Chapel Hill, sutured up a complex toe wound with a plastic surgeon giving advice over video. That was wonderful. That's a beautiful use of telehealth. Most of the time, we didn't have that level of need, but thinking about who's available sort of beyond that, just take care of coughs and colds, I think is very important. We'll talk more through the courses after I turn it over to Anthony. Thanks. Next slide.
All right, good afternoon. So my name's Anthony Nappi. brief introduction. I'm a long-term clinician, and I was lucky enough to be involved with some telehealth implementation projects over the past few years, primarily with the University of Virginia School of Medicine, which is how I got to work with Kathy Wibberley and Brian Ginnell. And Brian and I are going to talk a bit today about an approach to resilience or emergency preparedness that we pursued in rural Appalachia. So just to back up for a second, when I see those slides, we as a team of presenters met the other day. It was the first time I saw Steve's slides and that photograph and those numbers. I have a tough time getting my head around that, and I feel overwhelmed when I see that, really. And further, when I think about the field of emergency preparedness, it's huge. And so I start to think that's not a reason not to do something about it. But the overwhelming feeling associated with it makes me think, how can an organization be ready for something like that, something that vast and that severe? And I think the answer to that is by small chunks that contribute towards overall resilience and preparedness. And so I'm going to describe a bit about kind of our starting telehealth project in rural Southwest Virginia, and how we approached and essentially added a resilience component to that. And so as part of, like I said, formerly I was with the University of Virginia School of Medicine. We partnered with a rural area agency on aging, and kind of the initial objectives of that project were to really establish telehealth capability across this organization. The initial steps of that. So just briefly, the organization has about 7 senior day centers spread throughout, certainly rugged geography, as well as a main office. And our initial kind of foray and initial basic use case for telehealth was to establish the ability to provide virtual education for seniors concerning health and nutrition, and then a bit more specifically, initiate one-on-one nutritional counseling for seniors. So the registered dietitian would be remote, and then one of the seniors would receive a nutrition counseling session at one of those 7 senior day sites. And so that was the initial telehealth use case, but kind of in the lead up to that project, on September 27th, it happened to be 2024, was having a conversation with the executive director. That was the day that Helene made landfall, and that kind of spurred the conversation about how do we maybe add some resilience component to the overall project and start to contribute to that overall emergency preparedness. And kind of, along the way, we wanted to keep an open mind with respect to emergencies and how we talked about emergencies for several reasons. But one, just not to box us in with respect to, it can be certainly a weather-related emergency. It could be some kind of a geopolitical violence event type of emergency, or certainly, as we've seen, disease-specific with a pandemic kind of emergency. So we try to keep an open mind with that. The other reason really is essentially this was all grant-funded work. We know we're going to pursue other grants in the future, and I think it's a tough funding environment at this point. And I think there are certain phrases that are looked upon less favorably in the current environment. So we wanted to stay away from those phrases and just kind of keep an open mind with respect to the concept of emergency. And then essentially we also wanted to follow good implementation practice. So primarily making sure that those initial steps are achievable, and really trying to improve or maximize the likelihood for assimilation of the technology and assimilation of the resilience practice. And reduce the chance of abandonment of the practice. So overall, the project, like I said, was with a AAA, the Area Agency on Aging. The initial equipment ordering consisted of 3 mobile telehealth kits. So 3 tablets with HIPAA compliant conferencing access, and then a few kind of peripheral device, Bluetooth vital sign peripheral devices that we knew would be kind of for future use. But essentially the core equipment was 3 mobile telehealth kits. And we can go to the next slide, and I'll kind of along the way expand a little bit more about that. Okay, we're doing a video now, so we'll let's watch a video, and then I'll get back to where we're going. We've brainstormed a bit on our part. You all are the specialists in this region, but brainstorming on our part, we came up with, thought through kind of what are the components of resilience, and this isn't something we have to do like a mantra, but what are the components of resilience that are important to us? And really, we think that relationships are important. Readiness is important, and those 2, I think, components can be worked on before an emergency. This is relationships and readiness in action right now. But we also consider reconnection and recovery to be important components of a resilience.
They're not all on our. We work out of Big Stone Gap, but some of the vehicles are located in Lee County, some are in Wise County, and then some are also.
Certain models have connectivity. Low satellite internet router connected to the solar generator.
Those are solar generators. We've brainstormed a bit on. We can go to the next slide. So that was some footage from a drill that we did, kind of the initial emergency preparedness drill, and I'll expand on that a little bit. But with respect kind of to overall implementation of resilience, and I mentioned that in the video, we found relationships to be the bedrock, really. And so in our work with the AAA, we started with a couple virtual meetings, but then over some months had many trips to the region for site visits, in-person site visits, to really build relationships, build trust, and essentially kind of that process really enabled us to get a more comprehensive, meaningful assessment of the organization, helped us identify objectives and strengths and needs, and kind of what would work within the operations and the workflow of the organization, what would work considering the telehealth, the initial telehealth use case, and what barriers we might face with respect to resilience and overall telehealth implementation. And so those relationships, that solid assessment that we got from that really led to us and working with the organization, being able to develop a solid, manageable, reasonable initial use case. And so like I said, I explained kind of the telehealth aspect of the project to kind of work in a resilience in that context. We ordered essentially three kits to go with those 3 mobile telehealth kits. So in the technology with respect to resilience, we ordered 3 low orbit satellite routers with kind of subscription service, and then 3 solar generators. Because essentially our initial use case on the resilience side of the whole project was continuity of communication. And so whatever emergency would come up with respect to limiting movement of people or limiting communication between people within the community, we at that point prioritized maintaining continuity of communication. And so we felt like kind of adding that the generator and adding the Starlink. We use Starlink in this case, the low orbit satellite routers, to one of each of those for each mobile telehealth kit, kind of matched the existing workflow with respect to the already initiated telehealth aspect of the project. And so, once we came up with that use case, and once we started to come up with a strategy, we were able to focus on kind of the higher level objectives. So overall resilience. Hopefully, we're contributing to organizational readiness, reconnection, and recovery after an event. We can go to the next slide. So as I mentioned, I mentioned the technology, kind of with respect to implementation practices. We certainly kind of running parallel with the telehealth initiative. In the process of setting up that resilience with the satellite routers and the solar generators, identified key folks within the AAA to serve as champions and team members to kind of carry that resilience initiative forward. So we worked with the two IT staff members of the organization. They really spearheaded kind of the technology and testing kind of the mechanics of the devices. But then also the operations folks within the AAA, and even really important aspect of it was the transportation leadership of the organization. And so kind of that initial strategy, again, I think was driven and off of the relationship building that we really put a good bit of time into to think about. So if we're talking about 7 senior day centers across this organization, start to think about what would be good locations for an emergency and for that equipment to be deployed. Who would be in charge of each kit in the case of an emergency. So kind of that front end strategy. And then, like I said, that video was the initial drill that we essentially demonstrated proof of concept that we were able to achieve connectivity to kind of a remote part of Virginia from rural Appalachia to back to Charlottesville. And then that drill also kind of, I think, organically developed into conversations that would lead to kind of further readiness, further planning and strategy, and other considerations with respect to kind of at what frequency should we, do these practice drills and those types of important kind of considerations. I think, again, when I look at Steve's slides and I kind of get that overwhelmed feeling, I wonder, there's no point at which an organization can say, okay, we've achieved preparedness, we're there, and there's no static aspect to that. It's an ongoing process that never stops, really, and so I think, that's, again, I think back to the importance of the foundational relationships at the front end and then all the way through. And so at this point, Brian's going to dive a little bit more deeply into kind of the technology piece of our project and how we work through that with the AAA. So thank you, Brian.
Yep. Go ahead, next slide. Thanks, Anthony. So I have some slides with a lot of words on them, a lot more words than some of the other folks, as I'm going to dive into the technology. But I came into this from a different area from most. I work at UVA Center for Telehealth, and where I first got into emergency preparedness was a few years ago when we were intaking our first Ebola patients. And so I got into emergency preparedness around special pathogen management at a major medical center. And so that did sort of introduced me in a new way, in a different kind of thought process to some of these. As I've learned and been out in the field sort of like over the past few years and putting this stuff into practice, the things and the way I look at it have changed a little bit. And I think, you clearly have to, depending on where you are in the food chain, I guess, or in the organization, you have a different potential like thing that you're getting prepared for, whether you're a primary care physician's office within a community that you're trying to help your community, if you're people from within the emergency professionals from within the community, you have a different kind of aspect that you're looking at. And what I'd say is, and that really will change like how you're going to fit into the puzzle and what your preparedness may look like. And it's interesting as we've been out, over the past couple of years talking through some of this. Anthony and I were out in West Virginia last year, and we were talking through kind of what to do after an emergency. And we had a primary care physician kind of raise her hand, and she wasn't happy with her presentation because we were definitely had moved beyond the actual event, and we were talking about ways that you were sort of responding afterwards. But in our language, we had really kind of tied everything up, and we were talking about what was happening during the event. So like kind of while the rain's coming down and the expectation of how they're going to use the equipment. And it was a really eye-opening experience when you start to think about where people are during these events. And so like kind of what's happening within the community. Each one can be different. It can impact the community in a different way, as we've talked about today. It could do everything from like isolating your patients where they are. It can destroy, transportation mechanisms for you to get out of your house and to get to different places. So a lot of things could be different depending on what the impact is. And, I also come from working with UVA. We had things in our community where it was the health system responding within the community. But what I'd say is what that really got me looking at is the relationships behind this. And once the emergency is happening, it is not the time to try to create those relationships and to have some semblance of a plan on how you're going to respond. We're talking through a lot of technology, and I do have things like choose a telehealth platform. But what I want to say is it may not be choosing a telehealth platform because continuity of communication may be your goal that you've actually chosen. But we do spend a lot of time, if I'm looking at a telehealth idea, is to choose a platform that we're going to use. And I'd say if we're going to, in that, you need to select a reliable platform. Try to pick something that your people are already used to. We're using Zoom today for this call, and that is a very valid tool out in the world of emergency response and different things now. But so identifying the platforms that you're going to use during the emergency before it's an emergent time. Ensure the platform supports what you're going to need. If it's just a communication platform, it may not need quite as the high level of encryption. It may not need to be HIPAA compliant. If you are planning to use it for telehealth encounters, you have to think through a little more about the security of it and what it is. Does it integrate with your EHR? Me working at a major medical institution, everything has to be tied closely to Epic and our EHR. And if it's not, it's something different that physicians have to do. So again, how are you going to get the information? If you're out in the field running a telehealth clinic, how are you going to get it back into your EHR? And if the power's out and the communication's out, is there a manual process to get that data back into the EHR? So all those are things you have to think about when you're trying to figure out the platform that you're going to use. And some of the platforms do have some capacity to help glue some of that together. What we found during this is establishing the communication infrastructure really kind of rises to the top. And if you listen to what Steve was saying in the beginning, right after the emergency, there's a lot of need for people to be able to communicate out to their family members, let people know they're okay, being able to check in with different things. And so to establish those lines of communication for a community, and what they learned down in North Carolina was a lot of the systems were down. They didn't have necessarily Starlink on hand and ready to go at that point in time. And I think with more and more of these sort of services coming, people are getting ready and having those in their pocket. One of the things, if you have Starlink, if you ever have, I have an old system that I've moved to fiber now. But now they let me for $10 a month actually keep my Starlink active as a backup solution. But it used to be quite expensive, but now they've really started to bring the price down. Starlink has also brought down the price for actually entering and purchasing new hardware. So some of those things have really changed the cost and what it takes to get into it. Having a backup mechanism beyond that one. So, whether it's a cell service, Starlink, some of the other services that are coming, but making sure you have a plan if your main service goes down, what's that going to look like? And then the potential of even a toll-free number for people to call into a triage center. So if, for a patient contact, so having some sort of a source for people to dial in. We talked a little bit about in this, and I'll dig into the equipment a little more here in a second, but we talked about deploying medical devices. at the time of an emergency is not when you need to be deploying medical devices. A lot of this stuff has to be in place well before the emergency. So if you have patient populations that you've sent medical devices home and you have some sort of regular cadence, hopefully what you can do with emergency preparedness plan how to continue those conversations after an emergency has happened. So whether that's providing temporary solutions to the homes, I know in some of the areas, in some of the rural areas, we've worked to help people get Starlink into their homes through grants and federal funding. So really thinking through what is that last mile of communication. And then the bigger thing, if you're talking about medical devices out in the field, is how are you going to support those devices once they're out and in the patient hands? And so what's that last mile of support look like when they're having issues trying to connect to a video conference, or if you have blood pressure cuffs and things out, how are you going to support those tools while they're out there? So these are things you really have to think through ahead of time before the emergency happens. And you can go ahead to the next slide. And so this came out of, I think it was the FEMA playbook for emergency prepared. It's step 6. And it's what we've really focused on here today, I think, is once you have the equipment, is exercising the plan. And whether that's a tabletop exercise where you're getting small groups of people within the community together to talk through the usages, having drills of pulling the equipment out and going through the motor memory of doing it, so you know how to plug it up and you're not stressed out when there's something is happening, trying to figure out where the wires go. Functional exercises, and then full scale exercise. I'd say we were at a functional exercise when we went down to Southwest Virginia. But really, the key to those exercises is also identifying the people within the community that need to be invited. And that was some of the conversations that were extended during that day down there were fascinating to us. There were people within the community that had never actually talked. And they were learning about, one of the emergency prep professionals was there talking and was learning about the facility that we were working at that's within their community. And it's fascinating some of the disconnects, even within their own community. I mean, this is a major organization that has transportation services, a lot of different facilities around, and they would potentially be able to help during an emergency response situation. But those two entities had not connected. So really reaching out and focusing on those relationships and then practicing before the emergency happens. And so that's really around the, kind of prepping for it. And you can go on to the next slide now. And so here I'll start talking just more about the equipment. Some of the things that have happened, and some of this is always changing. So now with your iPhone, with emergency SOS mode, you can actually connect to satellites and use 911 services. And that's something that's really come out over the last 2 or 3 years. So you can, even if your phone doesn't have cell connectivity, it can talk to the satellites and it can send out some emergency information to emergency professionals. And so really understanding what those capabilities are. Google has added it to the Android phone. So not only is it on Apple, it's also on the Android side. Understanding cell networks and what's out there. So FirstNet and Verizon Frontline, those are both actually emergency provider networks. And so those both give you priority access in times of emergency. So if you're an emergency professional and you have the right type of phone or account, you would get kind of priority access. So really understanding the differences between those. Obviously, we've talked a lot about Starlink. Starlink Roam is the service that I talked about now, where it's $10 a month for me to basically just have the dish active. And then basically it would bill me if I go over like a terabyte, it bills you to kind of use it. But, thinking through having that connectivity, the expense of having a Starlink, especially if you're trying to set up a clinic, is fairly high. And that is one of the challenges with this, is how do you fund it and keep that active if you're using it for business purposes versus like residential, because it is quite a lot more expensive. But being able to plan that out and have that service available. There are more low orbit satellite services coming. I have it listed as Project Kuiper here, but it's Amazon's, and it's actually Project Leo now. And so I think they've launched around 40 satellites, and they're building another low orbit competitor to Starlink. So we are seeing new services coming online all the time now that can help extend that connectivity. Having these type of solutions out there, even if it's in an emergency response, and one of the things we heard from Steve is having a place, like I said, for people to come bring their phone in to potentially charge it and then to connect out and communicate with their loved ones is a great usage potentially for some of these as some of the triage centers. You can go on to the next slide. So one of the other pieces that Anthony had talked about is we spec solar generators, and this is a couple of them that are out there. Jackery is one that has kind of really risen to the top in the past few years. They have some very cost-effective solutions out there. Another one that I have significant experience with is the Goal Zero Yetis. Both of them offer, solar panels that go along with the batteries. The trick to these is really to understand like what your usage is going to be at the sites. You do have to spec these the right way to make sure you have enough power to run your triage center, and then having ones that are for backup. So thinking through the capacity you're going to need, and then if you're using it during the daytime and are going to continue using it at night, you may have to have extra batteries you're charging during the daytime to pull out. So you really do have to put some thought in to having the equipment out there. But the beauty of the solar generators is they do not require the LP gas, natural gas, or gasoline to keep them running. And so they do offer a lot, power in places that we have not been able to get it before. So you can go ahead to the next slide. And then further, once you start developing your telehealth kit, it can have a lot of things included with it, whether that's laptops, computers, and tablets at your triage center. Smartphones are definitely an opportunity now, and people have smartphones that can be added into the mix. So if you're monitoring a patient at home, being able to utilize smartphones, these high-speed internet connections, the webcams that come along with it. If you're setting up a telemedicine center, you have to think through things like headsets and stuff for privacy, so noise-canceling headsets, the microphones to pick everything up, power supplies and battery backups. And so it may not just be the power supplies. You have to think through like power strips and the actual extension cords you need to plug all this stuff up. If you get there with your battery, but you didn't bring enough cords, it's the little things you don't always think about when you're putting the kits together. Portable diagnostic devices, and again, it really depends on your patient population and what you're trying to do. But most of this stuff, you would really have to have the patients already have this at their homes prior to. So if you have a program where you have technology sitting at the homes and you're regularly checking in, I think it does present an unusual opportunity to be able to follow patients. But if the equipment's not out there, I don't think the disaster is the time to necessarily try to send something home with somebody unless you have a good support mechanism to really help with that. All right, and I think you can go on to the next slide, and that may be the last one. And so will be included, and this just has a list, some links to some of the equipment that we had. As I said, you have to really kind of base it upon what you're doing out there and what your goals are with the response. And so it may not be medical devices, it might just be internet connection so that you can talk. But I think the key to all of this is spending time before an emergency and thinking through what you're going to try to provide to your community and how do you fit into the puzzle. And I think that's the bigger key. So if you're a primary care physician's office, how do you fit into your community's puzzle and how can you help during that event? And so, and basically like making your office available, if you have some of these equipment, you potentially could help. But again, when an emergency happens, if that's when you're coming forwards, it's almost too late. So, really building those relationships ahead of time and spending time working through the drills. So, all right, next slide. And I think that's
All right. Well, thank you so much for that. We are open to questions. So if you have a question, go ahead and put it in the question box. But I'm going to tee up a couple things. So Brian, you talked about kind of moving from simple messaging to high bandwidth tools like digital stethoscopes or HD videos. And I know I have a Google Pixel, and I have attempted while in a state, a national park where there's no cell signal, trying to connect to satellite, and it took a long time. You had to stand and point your thing and wander around, and just to send a simple text message, a quick text message, could have taken 5-10 minutes. So, if we're thinking about like Starlink and HD video and equipment, like what are the limitations?
So that's a great question. And it's something we're all the time fighting. And I would say that if you look at it today versus when Starlink first came, and I was an early Starlink subscriber, and the network has greatly improved since then. The latency has gotten a lot better, but that's always been one of the challenges with the space-based internet. It's the distance things has to travel. It's naturally going to add some latency into the calls. What I have found is it has gotten good enough now that it works in most cases. But if you are in, say, situations like weather can impact it. So if you have big storms coming up, that could definitely, soften your internet connection during times. And then also like during weather events like we just had in the past few weeks, all the ice and snow and everything that came down could potentially impact the dishes and stuff like that. Starlinks do typically have heaters built into them to melt like ice and stuff off of them, but it also depends on what your hardware is. So, great question, but you do have to basically, testing and making sure you understand what the load is going to be and that you're getting the right service. The business class services do typically give you a better quality connection and they'll give you more bandwidth consistently. So I do think, if you're going to use it for a telehealth service to see patients, you do have to think through what that business class level and get the right level of equipment and stuff. So
Yeah, thank you, Brian. And I have a question for Anthony. So you talked a lot about relationships, and how that is important, and especially um, at the start. But then how do you think about the whole span? I work with rural communities and there's often a lot of turnover. People come, people go. And so how do you kind of sustain those relationships? Because you might not have an emergency for 2, 3 years. And then suddenly, something comes, and how do you sustain those things?
Sure. So, I mean, part of that, I'd say part of that answer is your front end strategy should include essentially what's the frequency or the cadence that we're going to repeat these drills. And so, knowing that, say you do it quarterly or say you do it twice a year, uh, you'll catch people either leaving the organization or new folks who come to the organization so that they are involved and become part of the team with respect to emergency preparedness and resilience. As far as and Brian alluded to this when he was talking, uh, as far as what we witnessed on the day of the drill, we had folks from the AAA, uh, kind of key operational folks from the AAA, but we also had the opportunity to invite county level emergency preparedness officials. And like Brian said, they didn't really know what their respective organizations' capabilities were. So, uh, kind of in the moment, the dialogue and the discussion and the relationship building was happening kind of along the way. And so, during that drill, folks planned for future visits. Well, I'm going to come down to the AAA and see what resources you have, and I want to see what the transportation department looks like, and see how that can fit into the wider county emergency preparedness plan, and how we can start to think through those important kind of points moving forward. So I think just the act of having a plan to repeat drills at some frequency helps that kind of that relationship nurturing and building along the length of the project. And like was reminding myself as much as anyone else, it's not that you reach this kind of state of readiness and you don't need to do anything more. It's this constant ongoing effort that's repeated, and important to that process is the relationship development and sustainment. And so we found that important. It was rewarding to see that kind of unfold in the moment on that and during that first drill. And so it really is, it's crucial to maintain that state of readiness and continually work on that.
Awesome. Thank you. Not seeing any questions in the Q&A box. So I'm gonna maybe Steve, and before we put up the last slide about lessons learned, um, I'm almost curious, like what is the community doing differently now? Now that you all have actually experienced a serious disaster, um, what have you seen change in your community in terms of, how we're ready for the next one?
Yeah, there's definitely work being done to sort of harden the infrastructure to make sure that power is more sustainable. There are lots of Starlinks sort of in boxes throughout the community. And additionally, it's been a learning opportunity for our FQHC on how to prepare for or how to respond to a disaster We are, 50% of our 150 patients were, or not patients, sorry, employees had some degree of damage at their home. And some lost their home. So having redundancy built in so that, who knows whose house is going to get hit, or who will be isolated due to a bridge out, having that redundancy built in for leadership roles is also something we've built out. But it is enhanced communication. It is a variety of ways that faith-based communities, the education community, healthcare, and sort of county and local government, including law enforcement, have all come together to be more aware of the interdependencies.
Yeah,
Yeah.
thank you. And maybe Aria, if you could put up that last slide for lessons learned. Steve, if you want to kind of walk over anything that you haven't already covered, in
Yeah.
terms of the lessons learned.
Well, I do think that planning for multiple outages is essential. I did upgrade my phone as soon as I could get online so that I could have the SOS texting because I was driving all over the county to these rural clinics and needed some way to communicate with people when it took 45 minutes or an hour to drive what normally only took 20 or 30 minutes. Make sure your devices are accessible, that people know how to use them. Spread the word with signs and in meetings whenever you have a chance and have a consistent message. Always connect and test with distant provider and having multiple people who can use the network, not just a select few. Sort of speaking to your turnover issue, Kathy, that retraining new people. The other part is in a disaster, how do people get to where the equipment's located? What are the solutions for that? They may lose a car, a bridge, and and is telehealth available remotely? We're nowhere near that point of being able to take a backpack into a home yet, um, but hope to be there in the next year.
Yeah, that's great. We do have one question. Was teledentistry provided at all during this time?
So, no, it was not provided. There's not a teledentistry presence in Mitchell County right now, or Yancey County, or really most of Western North Carolina. So it was really not an option for us to ramp up and use.
All right. Any other questions before we wrap up? Seeing none, we'll punt back to Aria.
Thank you, Kathy. Just a reminder that our next webinar is scheduled for March 19th. That will be hosted by the Northeast Telehealth Resource Center. Our webinar topic is still being finalized, but once it is, we will post it to the NCTRC events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. As I mentioned, we also have another survey where you can share your telehealth success story for a chance to have it and your organization featured in our monthly newsletter. Thank you again to the Mid-Atlantic Telehealth Resource Center for hosting today's webinar and to Dr. North, Anthony, and Brian for their presentation today. Have a great day, everyone. Goodbye.
Thank you.